A randomized clinical trial on safety and efficacy of low-intensity shock waves for the treatment of erectile dysfunction. Comparison of two treatment schedules. Current erectile dysfunction treatment options include PDE5 inhibitors, vacuum erection device, intraurethral suppositories, intracavernosal injections, and penile implants. Moreover, ED treatment attempts to improve erectile dysfunction without treating the underlying pathophysiology of ED. Shockwave therapy has been used to ameliorate ischemia and to promote wound healing in plantar fasciitis, Achilles tendonitis, and most recently in myocardial revascularization. Shockwave therapy is different from ESWAL for stones. In ESWAL, the energy is very focal and concentrated. Shockwave therapy for ED is radial, with a much larger focal volume where energy is spread over a greater area. In fact, the energy of shockwave therapy is approximately 10% of the energy for ESWAL therapy for kidney stones. The mechanism of action of shockwaves is not entirely understood, but two major theories have been proposed. One theory is that the shockwaves increase angiogenesis through the VEGF pathways. This is the theory that supports its use in myocardial revascularization treatments. The second theory is it will increase nitrogen oxide production from nitrogen oxide producing nerves, as well as increase the recruitment of stem cells. Shockwave is not FDA approved yet. However, the University of Miami got cleared by the FDA for a randomized controlled trial to evaluate the safety and efficacy of shockwaves for men with ED. The aim of this video is to demonstrate the baseline results of shockwave therapy for ED in a clinical trial setting at the University of Miami. 80 men is the target recruitment for the trial, and the study is designed into two different arms. Arm A is receiving 720 shockwaves every day for 1 week, and Arm B is receiving 600 shockwaves every other day for 2 weeks. Both arms will receive a total of 3,600 shockwaves in total. However, there is no control group for the present study. The primary objective of this study is to evaluate changes of the IIEF score from baseline to 1, 3, and 6 months after receiving the treatment. Further, secondary objectives are to study the sexual activity improvement according to the SEP, GAG, and EHS scores. Inclusion criteria comprises men with ED for more than 6 months and not more than 5 years, men taking PDE5 inhibitors that are responsive or non-responsive to treatment, stable sexual relationship for over 3 months, testosterone levels between 300 and 1000, an IIEF score between 11 and 25, and a hemoglobin A1C less than 7.5% in the last month. The following patients were excluded from the study. They were participating in another study in the last 3 months, under guardianship, had a history of radical prostatectomy, extensive pelvic surgery or pelvic radiation, a neurological disease, any use of antidepressant medications, penile and anatomical malformation, testosterone levels less than 300 or greater than 1000, or hemoglobin A1C greater than 7.5%. Here we describe the baseline data of the patient cohort in which we didn't find a statistically significant difference between the groups in terms of age, testosterone level, hemoglobin A1C, IIEF, and EHS scores. For the clinical trial, we are using a MoreNova device to generate the shock waves that will be delivered to the penis through the dual applicators. The advantage of this device is that it is not operator dependent. However, due to the conformation of the applicators, shock waves are not delivered to the perineal area. The applicator is covered with a condom, and gel is then applied to the surface of the applicators in a similar fashion to a standard ultrasound procedure. The patient is then placed in a sitting position, and the penis is placed on top of the applicators and locked with the use of a cover in order to keep the penis in a stretched out position. With this simple detail, shockwaves are distributed throughout the penis in its entirety. At this point, the clicks heard represent the shock waves that are being delivered to the penis. Here in this graphic describes the IIEF score improvement compared to the baseline. Patients receiving 720 shock waves every day for 1 week had approximately 2-point increase in the IIEF score at 1 and 3 months, and 6-point increase at 6-month follow-up. Interestingly, the group that is receiving 600 shock waves every other day for 2 weeks had a faster increase in the IIEF score at 3 months follow-up when compared to the other arm. However, so far, data has shown less of an increase between 3 and 6-month follow-up. Looking at the EHS score improvement compared to the baseline, patients receiving 720 shock waves every day for 1 week had a greater increase in the EHS score at 1 month follow-up when compared to the arm that was receiving 600 shock waves every other day for 2 weeks. However, at 3 and 6 month follow-up, both arms had similar EHS scores. Lastly, this graphic represents the IIEF and EHS scores compared between the two arms. In conclusion, shockwave therapy has been shown to safely increase the IIEF score in randomized clinical trials and single-arm studies. Despite this, shockwave therapy for ED is not yet FDA approved. In this study, we were able to evaluate the effectiveness and safety of the different treatment schedules of shockwave therapy in patients with ED in a clinical trial setting.